Good morning, everyone. This is Dr. Alpesh Maru, and we are going to discuss about autopsy finding of one hematological malignancy. Before going to discuss the detailed case or detailed topic, let's start a lecture with a case. The case says a 55 years male patient dead due to sudden respiratory failure and hemorrhage. On autopsy, external anemic body with purpuric spot, edematous fit, with internal examination shows marked splenomegaly, petechial hemorrhage. Patient had history of weight loss, anorexia, fever, weakness, lethargy, bleeding tendency, and lymphadenopathy. On peripheral examination, total count greater than 1 lakh, bone marrow aspiration showing hypercellular marrow with a high ME ratio, and cytogenetically, patient was positive for Philadelphia chromosome. This is the case given to you. Now you have to make composite diagnosis and then describe its autopsy finding. And this is the usual questions that is asked in your second theory paper in your prelim and university examination. So this is very important autopsy case. First of all, you have to diagnose based on the history given. And after diagnosis, you have to return all autopsy findings. So now we highlight some important features given in the history. First is age. It is 55-year male patient. The age is 55. Autopsy findings on external examination showing anemic body with purpuric spot. Now purpuric spot is again very important. There is something to happen with platelets. An anemic body but of which the hemoglobin level get lowered with a huge splenomegaly and petechial hemorrhage. Now history of weight loss, anorexia, lymphadenopathy, fever, weakness, lethargy, again showing some constitutional symptoms for carcinoma. Now regarding CBC parameters, peripheral blood examination showing greater than 1 lakh total leukocyte count, there is something happening bone marrow and blood. Now bone marrow aspiration showing hypercellular marrow with high ME ratio, and most important finding, that is PH chromosome positive. So with this given history, you definitely come to diagnosis. This is probably hematological malignancy, old age malignancy with high count with PH chromosome positive. Definitely this is the case of CML. Yes, this is chronic myeloid leukemia, and now we are going to discuss its autopsy finding. Now, before going to discuss, just I want to make emphasize what you are supposed to write in your autopsy finding. Now, here you diagnose the case. It is CML. Now, first few slides are regarding CML theory portion that we have already been. This topic has already been covered, but still I am going to discuss few important points of CML. But in your theory exams, you have to write autopsy finding. So after, based on the history, you diagnose the case. This is the case of chronic myeloid leukemia. And now what are the findings you should write in your theory paper regarding autopsy? So first of all, you have to write external examination in any autopsy or any case, like if there is a case of cirrhosis of liver, if there is a case of myocardial infarction, so there is a case of carcinoma lung, whatever the case, you have to follow a common pro forma. So first, an important finding, that is external examination, that includes whether the body is anemic or cachexic, whether there is any spot like this. In this case, there is purpura or ecchymosis spots, whether they have frothing in their mouths, edema, edematous feet or not, lymphadenopathy is there or not. So these are the things which you get idea from external examinations. Second portion, that is examination in situ. So you have to thorough make a incision from xiphisternum through umbilicus and open up abdominal as well as thoracic cavity. Straight away you have to collect fluids. Is in case of thoracic cavity there is pleural fluid, and in case of abdominal cavity there is this peritoneal fluid. You have to go for their examination, and then you check for visceral enlargement, whether there is splenomegaly or hepatomegaly is there or not. So that is examination in situ. So far you haven't done anything regarding internal examination. Now third portion, that is systemic or internal examinations. In that case, you have to check for all organs, and or we can say all viscera and their histopathology. So you have to check for GI organs or cardiovascular respiratory organs, kidney, CNS, spleen, and bone marrow even when you suspect any hematological malignancy. So there are some changes like congestional changes. There are some hepatomegaly or some organ enlargement, so you can definitely go for visceral examination. That is the third point. And fourth point, you have to send this viscera for histopathological examination, and that is the fourth finding, that is HPE finding. So now you have clinical external examination, examination in situ, systemic examination. So you have all clinical data. At the same time you have histopathological data. So next fifth step, that is clinical pathological correlation. So now you have to correlate whether if there is bleeding tendency and why there is bleeding tendency. Is there anything correlating in histopathological finding? If there is organal enlargement, why it is so? So you have to correlate all findings, clinical findings, with their pathology. And last, that is cause of death. So most of the cases, we have septicemia, hemorrhage and all the things, but at the end you must mention cause of death. And this is how your autopsy case or autopsy questions comes to an end. So these are the things we have to describe. Now we will see all the things one by one in this case of CML. So it is nothing but a clonal malignant myeloproliferative disorders and characterized by proliferation of all granulocytic cell lines. See, remember the word all granulocytic cell line is very important. And the word, one more important thing, that is clonal malignant myeloproliferative disorder. So it is malignancy. So marked myeloid hyperplasia, here ME ratio is increased. Why? Because there is high myeloid cells as compared to erythroid. So now what are the leukemogenesis? So what are how this malignancy arise? So simple genetic, we can say reciprocal translocation on two chromosome number 22 and chromosome number 9. So there is 922 translocation. This is the constant finding in chronic myeloid leukemia. How we can see? So this is the normal chromosome, this is short arm, this is long arm, P and Q. This is chromosome number 22 and this is 9. So now you can see this is the fusion T922, and this led to this short Philadelphia chromosome 22. This is T922, that is the reciprocal translocation. So now there is one gene in chromosome 22, the region is BCR, that is break point cluster region, and on chromosome 9 the region is ABL, that is abulsion leukemic virus. So PH chromosome is nothing but the fusion of these two, BCR ABL fusion. So again, you can see in this figure, this is ABL, this is BCR, and C, this is the fusion portion, right? So this is Philadelphia chromosome, short chromosome 22. And what happens once there is Philadelphia chromosome? There is increased transcription and increased translation. So uncontrolled proliferation will be there. So BCR-ABL fusion leads to increased tyrosine kinase activity, so phosphorylation of multiple substrates, and continuous mitogenic signaling will be there. So that leads to genomic instability. And this is the things where this apoptosis get reduced. So there is excessive uncontrolled proliferation of these myeloid progenitor cells, and this leads to chronic myeloid leukemia. So this is the leukemogenesis. We can say just like a pathogenesis in systemic examinations, in here hematology we have leukemogenesis. And now the drug role of imatinib is at this point of place, because once you give imatinib at this point of time, this prevent tyrosine kinase activity, and this is how you control this clonal proliferation, and we can say marrow get remission. So this is the drug of choice, imatinib. Now regarding clinical features, usually this is biphasic or sometimes triphasic. This is 40% asymptomatic. This is very important in case of CML as well as in case of CLL. Most of the patients are asymptomatic. Usually they have massive splenomegaly. There are very few conditions they have massive splenomegaly. One is CML. Another are hairy cell leukemia. Some other conditions are also there like malaria, but remember these huge splenomegaly, CML. Now there are some certain symptoms related to hypermetabolism like weight loss, anorexia, lassitude, night sweats. So these are the clinical features of CML. Now regarding features of anemia, in CML there is definitive anemia. So the symptoms like pallor dyspnea, tachycardia. Platelet functional abnormality suggested by bruising, epistaxis, this ecchymosis, menorrhagia, and hyperleukocytosis. This is nothing but hyperviscosity syndrome. So associated with thrombosis, there is increased purine breakdown due to gout, visual disturbance, priapism. So these are the things it happens in CML. So it is due to anemia, abnormal platelets, and hyperleukocytosis. Now laboratory findings. This is a very important landmark in chronic myeloid leukemia because this is the only leukemia. See, I repeat, this is the only leukemia where you don't need to go for bone marrow because you can diagnose it on peripheral smear with, we can say, condition apply with availability of cytogenetic testing. But still, definitely you can go for peripheral smear and make the diagnosis. Otherwise, rest of the leukemias like AML, ALL, CLL, you don't rely on peripheral smear only because you have to go for bone marrow. And if it is not get clear idea, then you have to go for immunophenotyping, that is the flow cytometry. At the same times you may go for cytochemistry, that is MPO NAC stains, and at this stage in the end you may go for cytogenetics. So these are the protocol in diagnosis of hematological malignancy. So now we just discuss some other hematological malignancy. See, basically this is the revision lecture, so I just describe 5 minutes regarding all leukemia in a very short summary. Basically, leukemia are of two types, acute and chronic. Acute are acute myeloid leukemia, that is AML, and acute lymphoblastic leukemia, that is ALL. And chronic again CML, that is chronic myeloid leukemia, and CLL, that is chronic lymphocytic leukemia. Now we discuss one by one. First, AML, that is acute myeloid leukemia. Now this is very important theory questions, laboratory findings in case of AML. See, important thing is age. It is young middle age. In case of CML, it is old age. So both myeloid malignancy, acute, that is AML, having young or middle age, CML having old age. Now total count almost greater than 1 lakh. Differential diagnosis have a very constant finding, that is greater than 20% myeloblast. So now if it is blast greater than 20%, leukemia stamped as acute, and if blast less than 20%, leukemia stamped as chronic. So definitely in CML and CLL we have less than 20% blast, and in case of AML and ALL both are acute leukemia, so there are 20 greater than 20% blast. Now one more constant finding in case of myeloblast in AML is OR rods. OR rods are present. You definitely stamp it as AML. And important theory aspect are FAB classification, that is M1 to M7, and WHO classifications. So these are the things happens in AML. Important thing is chloroma. You have to narrate that thing also. Second thing, ALL, that is the acute lymphoblastic leukemia. Age usually children. Three types according to WHO and FAB: AL1, L2, L3. L3, that is Burkitt's lymphoma. Count again greater than 1 lakh. Here blast is lymphoblast greater than 20%. Now sometimes it is around 60 to 70% in case of ALL. One more constant finding, that is CNS involvement in the symptoms in the form of headache, projectile vomiting. These are the signs denote CNS involvement. So this is about ALL. CML, we are going to discuss this thing in detail. So it is again greater than 1 lakh count, differential diagnosis, all cell lines, but blast less than 20%, ME ratio high, Philadelphia positive, old age. Yes, that is very important. And last but not the least, that is the CLL, chronic lymphocytic leukemia, again old age. But now as we can differentiate this from ALL by blast count less than 20, first criteria. Second criteria, again total count are quite high, sometimes maybe greater than 1 lakh, but second criteria is smudge cell. This is nothing but an artifactory cells, small cells, or we can say basket cells. That is the characteristic finding in CLL. Apart from these, there are mature lymphocytes around 40 to 50%. Atypical lymphocytes are also there, and these collectively hold around 80% of cell population. Small cell, atypical, and mature lymphocytes. Usually, these patients are again asymptomatic, and sometimes they have autoimmune etiology. So, this is how you can differentiate CLL from CML. So, these are the things by which you can differentiate all leukemias. Now, we discuss CML here. So, peripheral smear, but obvious HB decrease anemia, leukocytosis, count high, differential showing all stages of maturations from promyelocytes. PM stands for promyelo, MC myelocytes, metamyelo, band, and polymorphs. Basophilia. So this is very important finding, right? In case of CML, there is either basophilia or eosinophilia. So lastly, thrombocytosis or sometimes thrombocytopenia is even there. Now you can see these are the neutrophils, these are the basophils, metamyelocytes, and this is myelocytes, right? Myelocyte having abundant cytoplasm, right? This is neutrophil, you know it very well. Metamyelocyte having notch. This notch kind of notch like cells are metamyelocytes. Basophil having granule obscure nucleus. This is basophil, and neutrophil you all know. Now this is band cell. So typical band like cell. This is band cell. Now one more peripheral smell. You can see RBC having very much amount of pallor. So these are anemic picture. Platelets are quite sufficient number. Sometimes there are clumps even see. So the platelets are increasing in number. RBC destruction is there. Now cells. These are band cells. This is neutrophil. This is promyelocytes having granular cytoplasm. This is again, this is the perinuclear hop, suggest promyelocytes. This is neutrophil. This is nucleoli. This is blast. This is myelocyte. This is again myelocyte. This is myelocyte. So these are the all kind of cells. Neutrophils. So this is basophil. See this is again basophil. So this kind of cells, all cells, neutrophil, band cells, metamyelo, myelo, promyelocytes, few blast with basophilia or eosinophilia. This is the finding of CML. So this is just blast cell maturations from myeloid. One is this erythrocyte precursor, that is pronormoblast, that convert into basophilic, polychromatic, and orthochromatic normoblast, then polychromatic erythrocytes and erythrocytes. Regarding megakaryocyte, there is platelets, so they arise from megakaryocytes. Monocytes arise from immature monocytes, and then myeloblast that responsible for genesis of neutrophil, eosinophil, and basophil. How? Myeloblast, immature eosinophil, immature basophils results into basophils. Now this cell maturation is very important. So from myeloblast, this is promyelocyte. See, myeloblast having this kind of nucleoli within the nuclei and fine chromatin and scanty cytoplasm and large size of the cells. This is myeloblast. This is promyelocytes having large, again this is the largest cell among all myeloid cell line. This perinuclear hoof is there, abundant cytoplasm with granules, sometimes nucleoli present in the nucleus. This is myelocyte having abundant cytoplasm. Granules will be there either eosinophilic or basophilic, but there is no perinuclear rope, there is no nucleoli. Here slight dense nuclear chromatin. Now this is notch like cell, this is metamyelocyte. This is band and this is neutrophil. So these are the we can say lines of maturation from blast to neutrophil. So whenever there is shift to left means neutrophil, band, metamyelo, myelo. So these are the shift to left. This suggestive of either leukemia reaction or clonal proliferation is there, then it is malignancy. Now you definitely diagnose the cell. This is metamyelocyte. This is basophil, neutrophil, myelocyte, basophil, metamyelocyte. This is blast. This is again blast, basophil. So this kind of cells will be there, all kind of, we can say, maturation on the same slide. See, these are the neutrophils. These all are neutrophils. And this is again myelocyte, myelocyte, metamylo, myelocyte, myelocyte. These are the neutrophils, and this is blast. So these are the things you can definitely see under microscope. See one more. This is basophils. This is neutrophil. This is myelocyte. Again, this is myelocyte. This is not clear cut blast because it has no nucleoli, though it is again still tricky. And this is again promyelocyte. So these are the cells, all kind of cells will be there in the on the peripheral smear. One more cells, one more slide. This is band cell, and these are the blast. One, two. This is promyelo, right? Abundant, large size abundant cytoplasm, again promyelo. So these are the all kind of cells populations are present on peripheral smear that suggest of CML. So now bone marrow, hypercellular marrow. So there is reduced fat cells. How to judge whether the marrow is hypercellular or hypocellular? That is based on fat space. If fat space are greater amount, it suggests this marrow is hypocellular. If less fat, hypercellular. ME ratio, usually it is 4:1. Myeloid erythroid ratio 4:1, and it is increased sometimes 10:1 to 13:1. So this is a constant finding in CML. Now blast usually less than 10, overall less than 20, and megakaryocyte increase. This is again a reactive, or you can say a compensatory megakaryocytic hyperplasia. So megakaryocytes get increase. See, now megakaryocyte, again megakaryocyte is the largest cell on bone marrow. You can see even on the scanner. See, these are the megakaryocytes. 1, 2, 3. So these are the megakaryocytes. Even you can see on the scanner view. Now laboratory findings. NAP score get reduced. That is NAP or LAP. That is leukocyte alkaline phosphatase, or you can say neutrophilic alkaline phosphatase score. Why? Because most of the cells having shift to left. So less neutrophils but more premature cells, they goes towards shift to left. So less number of alkaline phosphatase activity present. So that's why NAP score reduced. This is the differentiating point CML from myeloid leukemia reaction, where you will have NAP score get higher than this leukemia. LDH get increased and cytogenetics showing Philadelphia positive. Again, this is the slide of bone marrow finding of CML. Now see, these are the blasts. See, this is the nucleoli, clearly appreciable nucleoli. So these all are blast. 1, 2, 3, 4, 5, 6, 7, 8, 9. So usually this may be a slide of blast crisis of CML, but these all are myeloblast. So there are 3 phases of CML. Now this is the thing which I want to emphasize: chronic phase, second accelerated phase, and third one blast crisis phase. Usually we have seen most of the patient on chronic phase, that has a very good median duration survival 5 to 6 years. Accelerated phase have 9 months survival, and blast crisis 3 to 6 months. So it is very important to diagnose at this stage. Total count greater than 2 lakh. Blast, here it is 20, not 30 by mistake. So greater than 20% in blast crisis. Otherwise in 2 phase they have less than 20. Basophilia is there. Platelet usually increase. In blast crisis it is decrease. Myeloid hyperplasia is there, so ME ratio get increased. Cytogenetically Philadelphia positive, BCR ABL fusion present in all 3 stages. So this is the differentiating point. These are the differentiating point in chronic accelerated and blast crisis of CML. Now first of all, chronic phase. Again, majority cases are diagnosed in this phase, more than 80%. Greater than 2 lakh count, less than 20% blast, prior to imatinib survival at 5 to 6 years. Second accelerated phase, here again blast in between 5 to 20. Second phase, thrombocytopenia and sometimes progressive anemia. Symptoms regarding this phase are fever of unknown origin, bone pain, and there is definitive hepatosplenomegaly. Median survivor again 3 to 18 months. Third stage, that is CML blast crisis, and this is the final phase of CML, greater than 20% blast on peripheral blood as well as bone marrow. Now symptoms are typical malignant symptoms like fatigue, bleeding tendency, anemia, bruising, ecchymosis, hepatosplenomegaly, CNS dysfunctions, all infectious complications, and median survival rate is quite short, around 3 to 12 months. So this is a quite dangerous stage, and very important thing is you have to differentiate this stage from AML, because in case of AML they have greater than 20% blast, and these blasts are of myeloblast, and here again CML blast are myeloblast, and that raise, or we can say go beyond 20%. So now whether we have to fit it into AML or CML blast cases, that is again a very tricky things had happened to hematopathologists. These are the very day-to-day practice for them. You must go for immunophenotyping, you must go for flow cytometry, you make a panel of that particular cell lineage, and you may come to diagnosis. One more thing, that is ph chromosome. Yes, definitely in AML there is no Philadelphia chromosome, so this is again cytogenetic study in this case is very important. Now this is all about few important findings of CML. Now let's get started of post antemortem examinations and post-mortem examination of CML. Antemortem. So before that, they have clinical history like fifth decade male having complaint of weakness, lethargy, fatigue, fever on and off, weight loss is there, bleeding tendency, epistaxis, hematemesis, bleeding per rectum. Now important thing is bleeding gum. It is again a very important thing. CNS crisis, respiratory crisis in the form of cough, hemoptysis. If there is involvement in the eye and ear, there is deafness and blindness respectively. So these are the clinical history. Now signs: hepatosplenomegaly, ascites, lymph node enlargement. These two are constant finding. Third one is gum hypertrophy and bony tenderness. Signs of anemia, muscle wasting, and emaciation is there. So these are the things that happens in CML. So these are the very important signs and symptoms to find out CML on external examination only. Laboratory diagnosis again on antemortem you can say anemia is there, a one leg count. This is very important. Myelocytes and metamyelocytes count 20 to 30%, and bent and mature neutrophils count 40 to 50%. So this four cell line having almost greater than 60% account of cells. Basophilia around 3 to 4%, and blast less than 20. So these are the finding of CBC finding of, or we can say PS finding of CML. Bone marrow again AMI ratio increase, lab score decrease, and Philadelphia BCR ABL fusion T9022 reciprocal translocation is there, and bone marrow are always hypercellular. So these are the bone marrow findings. Now post-mortem findings. So you have to make antemortem findings like history, signs, symptoms, PS, and bone marrow finding. Now post-mortem. So as we have already discussed, first point, that is external examination. So you can see by seeing the body of the patient, you can say this is anemic body having purpuric spot, edema is there, some frothy fluids comes out from the mouth, nose and ears, and there is lymphadenopathy. So these are the things you definitely judge on external examination. Now examination in situ, once you go for incision, you may find enlarged spleen, enlarged liver, fluid in the peritoneal cavity, pleural effusion is there, voluminous lung due to congestion. So these are the examination in situ finding in case of CML. Abdominal cavity, enlarged spleen, enlarged liver, fluid is there, thoracic cavity, voluminous lung with pleural effusion. Now third portion, systemic examination. You must show if you suspect, now in this case you suspect hematological malignancy, go for bone marrow examination. Usually grossly it is this normal yellow marrow converted to red marrow, and it is cavity get enlarged and congested. Spleen again get enlarged. Weight around 1 to 3 kg, and it is occupied two-thirds of the abdominal cavity. Grossly it has a thickened capsule with adhesion, smooth pale surface. On cut surface, very important thing is plenty of small pale areas of splenic infarct, because constant splenomegaly, due to this leukemic infiltration there is lack of blood supply. So but obvious finding is splenic infarct, so pale area all over the surface. So internal examination, first bone marrow, so normal yellow marrow replaced by red, spleen enlargement with pale area. GIT, gum hypertrophy and tonsil enlargement, constant finding in case of CML. And you may find congestion and petechial hemorrhage in all viscera, start from esophagus, stomach to intestine and rectum. So all have congested and petechial hemorrhage. CVS, cardiovascular system, again they have fluid accumulation with pericardium, myocardium, endocardium showing petechial hemorrhage. It is again a constant finding in CML. Third one, respiratory, again pulmonary edema, pleural effusion with petechial hemorrhage on the visceral and parietal pleura. You may find secondary bronchopneumonia. Now CNS, again all meninges showing petechial hemorrhage, and kidney are swollen and dull grey appearance. So these are the systemic findings from bone marrow, spleen, GI, CVS, RS and CNS and kidney. So once you go for all examinations, so these are the constant finding, common finding, petechial hemorrhage in all things, congestion is there. So lastly, you have to go for histopathological examination. That is the leukemic cell infiltration. First thing, you must find all viscera having leukemic cell infiltrations. All vessels get congested, and there are small area of infarction all over the body. So these are the histopathological findings in all organ and viscera. So these are the constant finding on autopsy. Now last thing, this is the clinical pathological correlation. As we have already discussed, okay, bleeding tendency is there. Why? So here you correlate the things because you have leukemic infiltration in all viscera. So this leukemic infiltration, but obvious, this leukemic cell always obliterate end artery, and this leads to bleeding. Second, organ enlargement, again this is due to leukemic infiltration, organ enlargement is there. And first and constant finding petechial hemorrhage, as we have already seen all viscera having petechial hemorrhage, and it is due to infiltration of end artery by leukemic cells. So all things get correlated. These leukemic cell infiltrates leads to petechial hemorrhage, organal enlargement and bleeding tendency. So you definitely correlate the things with clinical and histopathological findings. So your diagnosis are stemmed as the death is due to CML. Now cause of death, these are generalized things. Usual all we can say bronchogenic carcinoma, or you have myocardial infarction. All the things have their own cause of death, but the constant finding is massive hemorrhage, generalized septicemia. If there is some organ like spleen, intestine, there is perforation and rupture. And lastly, cardiorespiratory arrest. So these are the things you have to mention on cause of death. In case of CML, we have massive hemorrhage due to petechia, septicemia because patient's immunity get lowered. There is secondary infection is there, and sometimes respiratory failure. So that's all about autopsy finding of CML. I hope you all get a proper idea of what to write in autopsy proforma, history, external examination, examination in situ, systemic examination, histopathological findings, clinical pathological correlation, and lastly cause of death. And I have already described various differential diagnoses of leukemia from AML, ALL, CML, and CLL. So that's all about our today's topic. And if you find any query, you may feel free to ask me anytime. Thank you very much.